Joanna is a passionate advocate for women taking control of their health needs. She is particularly driven to help women who are experiencing changes associated with midlife to have open and honest discussions around their health concerns and the treatment options available. Dr. Sharp has a long-held commitment to women's health specifically, and we welcome her to Pure Health Hub. Welcome, Joanna.
Hi, Lindy. Thank you.
Now, let's start with these numbers. Now, 34 is the number of known symptoms of the menopause. I feel like I probably had about 29. 85% of women will experience the menopause's most common symptom, hot flushes. 51 is the average age of an Australian woman who becomes menopausal. And 5 to 10 is the number of years a woman can experience menopausal symptoms. Now, they're all quite big numbers. So in what should be treated in a transformational time instead of the change, after all, 4 million Australian women experience this significant period in life. So why is it that there has been so little information, support, and knowledge shared with women going through it?
Oh, I think there's so many factors that come into that, Lindy. It's hard to pin it all down. I mean, I think that there's a significant cultural element to it, and very much it is about, our mindset around what it means to go through this chapter of our life. Because as you say, when it, goes for 5 to 10 years, this is not just a passing illness. This is a significant chapter of your life. And it's interesting, to look even at the word menopause. It's all about a woman's fertility ending, and it's almost a bit of a construct of the patriarchy to consider women's worth is tied to their fertility, and this new part of their life is now their infertile part of their life. So, I mean, I think it's just, historically, for whatever reason, that's where we're at. I think we can upend it, though. We can really look at it in a completely different way. And there's this really lovely hypothesis called the grandmother hypothesis. I don't know if you've heard of that, but it's just all about how women, our ancestors in the African savannah would have lived in tribes, and there would have been some women who would have lived longer and been healthier into their latter age. And they were then able to help more. So they, could support the younger women. And it actually led to the young women having more children in that tribe. So it almost selected out the genes for longer living, healthier human beings, having those women, because their tribes would then have more offspring. And it actually shows true even in modern day life that when a mother lives closer to her female offspring, they will have more children. So it just goes...
Yeah, sorry, go on.
It goes to that point of, this is not a time of your life where you're redundant. It's actually a very useful and positive and beautiful part of your life. And, in some ways there's a good, chance it actually drove our species forward.
Yeah. It's an interesting point that you raised there, because, it's a little bit like it takes a village to raise a family. And obviously the grandmother syndrome or grandparent theory that we talk about is keeping women active and their minds active and all of that, which of course, changes that whole moving into a more of a sickness space than a wellness space. But I want to talk about a bit about that later.
I think I was just going to say that I think the big part of it is that there's not really any formal time where we stop and sit down with anyone, who, necessarily has any great wisdom about this to say, okay, what is this chapter about? What's going on here? We know that hormones are powerful. We see it in, pubertal teenagers who sometimes go completely off the rails. Hormones in pregnancy and after pregnancy can be, really, have a huge impact on a woman's brain and, sense of self. But we do have, high school to learn about puberty. We have antenatal care to learn about what's going to happen through pregnancy and after. But we don't have a formalised time where women sit down and find out more about menopause although we have, well woman checks with our GP, it's usually, a lot to fit into a consult as it is to have a pap smear and a breast check and look at your fertility and check your blood pressure and see when your last bloods were done and just do a general checkup. And that's also now been shifted to 5 yearly because the cervical screening test is so good that we don't need to do it every 2 years. So it's not happening as often.
Yeah. So that connection. And I think you sort of also raised a point a little bit about that community. A lot of women used to talk to each other in that village and say, and there was help about what might have helped a particular symptom or whatever. There was just that normal sort of community to chatter and
yes.
Which we don't have anymore either.
Well, I think we place so much value on youth as well. So there's a lot of shame around not being youthful anymore. It's huge amounts. And so women don't want to acknowledge it. I feel like my mum for the last 20 years has been saying, I guess I'm middle-aged, as if middle-aged is the most horrendous thing. But in fact, middle-aged just means, I'm in my mid-40s. If this is the middle, that's pretty cool. I've got another 45 years to go and look at what I've already achieved. And there's that again.
It's so true. I think, it has had a real negative connotation the whole time. And I think, and I must admit, when I started menopause, I'm 56 now. When I started menopause, it was kind of like, just sweep it under the carpet, pretend it doesn't happen, even though I'm like, so not sleeping and flushes and all of that. Because I was a bit embarrassed about it because it meant I was old, right?
Exactly.
So,
yes.
But then when I realised that, I thought that was just my little world, but it's everybody's living like it's crazy. It's
exactly
crazy. Why why we started this really.
So just talking about it is so powerful. Just normalizing.
Absolutely, which is the whole mission here, indeed, just to make it like a period or IVF or whatever it might be. We're all going through it.
It's a chapter.
Absolutely. All right. So what are the most common of those 34 known symptoms?
Well, most of the symptoms that you experience during menopause are due to the shifting hormones and predominantly the impact of estrogen going down as you stop ovulating as often and you come towards the end of your fertile chapter of your life. So it's really about the impact of estrogen, and we realise how almost protective estrogen is on a lot of our organs and tissues, which in fact is why up until that point women have a much lower incidence of things like heart disease and stroke. But as the estrogen goes down, one of the impacts that we see a lot in women, and you mentioned the 85% getting hot flushes, is the vasomotor or vascular impact. And it's almost like those blood vessels are just going a bit bananas and you get these surges of blood and, heat, right through the core of you, and vascular sort of migraines. Some women feel very lightheaded. Some of these things are not, very well studied in terms of, what is the true underlying, what's happening in those blood vessels, but it's, essentially some impact of losing the estrogen. Those blood vessels are not behaving as normal. So that would probably be our biggest one that we see. Then there is the impact of losing estrogen on, the nerves and the brain. So some women experience quite significant mood change. And I mentioned before, after pregnancy, that's, postnatal depression and even psychosis, is because of rapid fluctuations in hormones. So again, we just don't probably recognise how powerful hormones are and what that can feel like when you're, at sea with your hormones. So so there's mood changes, insomnia, tiredness, and then joints as well as another thing. So the impact of losing estrogen on your joints, it seems to be that globally estrogen helps to maintain the glycogen in your cells and maintain sort of the hydration. So as you lose that, in your joints, they get a little bit more creaky, maybe a little bit more painful, maybe more prone to sort of osteoarthritis. In your muscles equally, you can get, more strains or, plantar fasciitis or, Achilles tendonitis, those sorts of things that crop up that you might never have had before because the muscle's just not as happy as it was with the estrogen around. In your skin also, we notice some symptoms like dryness and itchiness. And then the other big component that we see as GPs is the genitourinary impact of losing estrogen. So the impact on the vagina is that, that wall loses the glycogen, loses the hydration. So often you get vaginal dryness or itch, discomfort with intercourse. And then because the urethra is so close by, you also get urinary symptoms. So they might have, more urinary frequency, getting up at night time to go to the toilet. Some are more prone to UTIs, and a lot of women don't realise that that's actually due to the menopausal shift in hormones.
Yeah, absolutely. Gosh, there are so many, even I had to tick off there for a second. So many, but estrogen is the key, isn't it? So there are, gels and things that you can.
I think it's important to note that estrogen is the key, but not all women need it. And I think what is key is how quickly your body shifts. If your estrogen drops rapidly, so say, for example, a woman who has had a hysterectomy and her ovaries removed, suddenly, estrogen is gone, it will often be quite a devastating, impact on all of those organs and tissues, and her symptoms can be quite horrendous. Some women, about 20% of women, will sail through menopause, and for whatever reason, they're probably just that woman who has a nice step down gradually. So not everyone needs hormone replacement. It's considered more of a hormone therapy for some who do need it now.
Yeah, exactly. Well, I guess just while we're on the symptoms, what might be some of those symptoms that are not so common that women might not even consider it to be part of the menopause?
Yeah. I think that some women have this notion that it's not menopause unless you've stopped having your periods, but in fact, you will often have bleeding, in the lead up to your actual menopause. Menopause is just a point in time where you've had 12 months of no periods and now you're menopausal, but you might have had 5 or more years in the lead up, and in that time you can have quite, irregular periods or erratic bleeding. Some women get very heavy bleeding, so they might be thinking, well, this is not menopause, this is the opposite of menopause, but actually it can be that imbalance in hormones that's causing more build-up in the lining and therefore, more erratic bleeding. I touched on the skin changes, and they're quite interesting because I think it's a combination of both the impact on nerves in the skin but also the dryness in the skin cells. But some women get this symptom called formication, which is the feeling of little ants crawling on their skin. So it's sort of prickly sort of feeling, which is very typical of the menopausal changes on the skin. And then when I touched on brain symptoms before, one I didn't mention was brain fog, which is quite an interesting one because it's sort of a term that's been bandied around a lot in recent years. And there's lots of different times where we sort of say, there's brain fog associated, and probably they're generally hormonal sort of times.
Well, that's probably true, right? Because I think we've, talked about brain fog at Pure Health Hub before, and there's been a number of reasons for that, overwhelm and all those sorts of things. But I think we dismiss it as being part of the menopause, but of course it can be, and hormonal, as you say. Up in PMS and things as you get a bit older. So
exactly. And I think the important thing, and what can be very reassuring for a lot of women is that, because I think a lot of women panic that this brain fog is now there permanent, and in fact it could even get worse with time. But again, it's just usually a period of time where, and I think there will be more and more research coming out about this because there are more neurologists looking into the impacts of menopause on the brain.
Yay.
Yes, which is really interesting stuff. The brain is just, it's like outer space. There's so much there. It's just fascinating. But one theory that I've heard a fair bit is almost this concept of, it's like your brain is rerouting itself. You've been going on one channel and you've been going hard on that channel, and now you're going into a whole new phase of your life, and it needs to drag everything over to this new route in your brain. And that's quite uncomfortable, and it can feel like you're very lost in between. But most women will come out that other side and go, oh, that was horrid, but I feel better.
Well, I think that is the thing, right? So we do come out the other side feeling, normal. Because I think, we often have put the menopause in this sickness space and instead of the wellness space. But it's, as you say, it's a period of time.
Yes.
Of change and adjustment. And often we go kicking and screaming into that change and adjustment.
Yeah.
Right? I mean, things changing. I don't want things to change. I want it to keep going.
Yeah, of course.
So I think, it bothers me that it sits in a sickness space rather than a wellness space.
Yes, me too.
And I think you've sort of answered this question really. It's what's changed or what is changing. And I think also the fact that they're actually now doing more medical research into the menopause is extraordinary, because us poor women have often been neglected when it comes to medical, particularly around hormones.
Absolutely.
Been neglected, right? So I think, it's just making sure, what do you think? Do you have something like an anecdote or something you could share that is what's changing or has changed, that's ensuring that we lead fulfilling and active lives and continue to?
I mean, I think it is very much, like we said before, about talking more about it. And I think women are very good at that. And it's just, we're finding our place to find those channels to talk about it more and, help our sisterhood to get through this period. And in order to reframe how we see midlife and menopause, so that we're not so negative about it and we can actually look at what the potential is there. And from a medical perspective, there's actually so much, potential to come in at that point before any chronic diseases might develop and help women to optimize their health. So, ensuring, their diet and exercise are optimized, and looking at their bone strength to prevent osteoporosis, looking at all their family history and risk factors for things like diabetes and heart disease, checking their cholesterol. So there's just, so many layers of things that are very proactive that can help a woman to feel, that she's going into this next chapter as healthy as possible.
Yeah, exactly. And I think, sadly, we mostly are running like crazy, and then it kind of hits the wall and we go, okay, now we've got to start doing something.
Yes.
But you're right, it is obviously about making sure that we're maintaining good health. And look, in a GP's defence, I will say that up front, a woman's physiology is different, so therefore their experience is individual. Plus our GPs, as we were saying before, they've got 10 to 20 minutes to try and identify the issues and prescribe a treatment plan. So I do feel for them. What could our GPs be doing more to ensure that we receive the additional and individual support and treatment we need? Or likewise, who should we be seeking out?
I mean, I think you make a really good point there. I think that GPs, particularly these last 2 years, have really been working hard. And I think a lot of chronic disease management has had to fall by the wayside, and identifying risk factors, because there's been so much acute health, related to the pandemic. So I think something that, GPs and patients could do and could become almost the norm is to have an assigned consult for menopause or perimenopause. Like I said, it almost gets sort of touched on during your well woman check, when you've had your pap smear and your breast check and you're getting your form for your mammogram, and, it might just be, a brief mention during the consult. But I think even to set aside, a proper long consultation to sit down and say, we're not going to do anything else. We're not going to, check other things, or, don't bring your kids along and, we'll look in their ears and check their throat at the same time and run around and give them a jab. Let's just focus on you. And I think that is something that a lot of women struggle to do, is prioritising themselves at this point of life, where they've got
at any point in life, right?
Yes, but it's almost cumulative. And by your 40s and 50s, many women have got so many, priorities, and they're at the bottom. So I think that really needs to be prioritised as something you do, ideally annually, is sit down and say, where are we up to with hormones? Yeah. How's, where are we up to with menopause? Yeah. How are you feeling? How's your mood? What are you doing with preventative stuff like diet and exercise? And, any symptoms that you're getting with menopause. What things can we do to help those? What are you doing, lifestyle-wise? Would you consider medications? And I think something that makes these consults so much more complex is even if the GP can fit all of this stuff into, a 20, 30-minute consult, the patient actually can't absorb that amount of information.
It's overwhelming.
And decide on the spot what they want to do. So I think that it's also about resources. It's about having, good fact sheets that the GP can give the patients to have a think about what the options are. Often, if I have a patient with HRT, and I'll look through their risk factors to decide if they would be appropriate to consider, hormonal treatment, then if I had a patient with hot flushes, I was thinking not HRT. So we'll look at hormones and whether that would be appropriate. So then I'll give them a fact sheet on that. And then some people automatically, definitely wouldn't do it, don't want to know about hormones. I might still say, well, have a read about it. I understand there's a lot of hesitation. There has been a lot of bad press, but I can talk you through the risks. By reading this and taking it away, you'll have more time to understand. But there's, obviously it's an individual thing. We've got to look at what is best for you. Here's another fact sheet on the non-hormonal treatment. So I think it's just giving them those tools so that they've got the best science, to help guide them.
Exactly. And the other thing that we're about is, we have to own our own health journey, right? So we need to go in there armed with what challenges we are having, whether it's hot flushes or whatever it is, sleeplessness. But we need to go in there with more than just that. I've been a bit sleepless. It's like, well, you've got to look at it holistically, right? So it's important that we take that ownership and go in there with that extended consult, I think is an important part. Would you say that? Would you?
Absolutely.
Yeah. So what are some of the treatment options available today? And does hormone therapy remain a viable option? And I will just say that for me, hormone replacement therapy was a godsend. I got through the 5 years, and I can tell you after the first, putting up with it for 12 months or so, and then finding HRT, and there was a wonderful doctor at Royal North Shore in Sydney, and he was fantastic and explained it all and made me feel really comfortable. And I could not have done without it, in my view. So is hormone therapy, replacement therapy, still a viable option?
Oh, absolutely. So, it's always been there. It's obviously evolved over time and, there are always sort of newer options, and the research might suggest, somewhat slightly safer options. So, for example, we know that the transdermal estrogen, which is patches and gels, actually are slightly safer in terms of the risk of causing blood clots than taking a tablet. But equally, we know that the risk of having a blood clot is actually greater if you're a smoker or if your BMI is over 35. So, you certainly, we'd be more cautious about giving a woman with those risk factors a tablet, and we might only think about, the transdermals, but also looking at reducing their number one risk factor, which is their weight, and helping them with that as well. Definitely menopausal hormone therapy is an option, and like you said, can be, just really a revelation for some women who've been putting up with particularly hot flushes. But there can often be a big flow-on effect. Once you've treated the hot flushes, that improves their sleep disturbance, or they've got less of it, they sleep better, absolutely. Their mood is better, their libido improves, their relationships improve, their stress goes down. So there can be a huge flow-on effect of treating that sort of, key thing that's been really bothering them. We also have, some hormonal therapies that are better for women who have very dense breasts, just because we know that the hormone treatments can sometimes actually stimulate the breast tissue and cause, tenderness, and make it more difficult for them to have their mammograms as well, for the radiologist to see the breast tissue adequately. So there's one called Livial or Tibolone, which is very good for that, and that can be particularly good for libido as well. Obviously, not everyone can have hormone therapy, and that's particularly women who are coming into us having never had hormone therapy after 60. That's not a good time to start it. Ideally, we want to start it within 10 years of their menopause and before 60. And also, we would usually review it at 5 years, but absolutely, in many women, they may need to continue beyond that. It's just about tailoring it to their risk factors and what works for them. It's very much for some a quality of life thing.
Yeah. Well, it was for me, I have to say. For me, it was like, well, and obviously they did the assessment based on, my health and things, but it certainly was for me. I would do that in a heartbeat if it even at the other end was shorter, because it's quality of life, right?
Absolutely.
It's the chain reaction of everything.
Yes. I mean, I think as with every medication, there's always going to be pros and cons. There's always the potential for side effects and complications. And I think it's just that the studies that were done were not great studies to begin with 20 years ago. The media really blew up some of the statistics and actually framed them in the wrong way. And subsequent reanalysis of those studies has shown that it is actually more beneficial for a woman with no other risk factors such as breast cancer or other hormone-dependent cancer or a past history of clots to go on the menopausal hormone therapy for their symptoms.
Yeah. Wow. Oh, sorry.
So, but there certainly are non-hormonal treatments as well. I didn't touch on that. There are some antidepressants that are particularly good, probably at tapping into that nerve side of the impact of estrogen loss and reducing the impact on your mood, but also on the hot flushes. So there's a couple of antidepressants that are very good at reducing hot flushes. And then there's a pain medication, gabapentin, that can be very good for particularly women who have that joint pain associated with their menopause, but also it helps the hot flushes.
Yeah. I love the fact that you pointed out, we talk about hot flushes like that's in isolation, but in actual fact, you're right. It affects your sleep. It affects your libido. It affects all of those things. So it's not just fixing the hot flushes, it's everything else.
Yeah.
Extraordinary. So I'm absolutely chuffed that you've started Juniper.
Yes.
So can you tell us a little bit about Juniper's program? What does it entail?
Sure.
And does it incorporate contemporary medicine and complementary health treatment?
It does, absolutely. So I guess the idea was to take what we talked about before in terms of what could be done in the GP surgery to help a woman, navigate through menopause and take that online. So a woman can do it, at her leisure, go online to myjuniper.com and fill out a questionnaire, and then she'll be matched with one of our doctors. There's a group of GPs who all have a special interest in women's health, and we're all guided by a very well-respected gynecologist who helped to develop all the protocols that we use. And that way we can sort of get a very standardised history from them to make sure we've got all of those risk factors before we decide what's going to be the best treatment options for them. And we've also assessed their various symptoms and how severe they are. And then once we've done all of that and gone backwards and forwards, it's what's called asynchronous text-based consultation.
All right.
So essentially, we're not necessarily there online at the same time as the patient, but we'll receive their questionnaire and we'll put the questions out to them. When they've got time, they'll come back to us. And we might give them, like I said before, some of those resources to have a read and say, come back to me with any questions. So we might be going backwards and forwards with the woman, 3 days, 7 days before we say, I think this is going to be a really good treatment option for you. How do you feel about it? Should we go ahead with that and give it a try? So it's very tailored to her individual circumstances, and as well as, the hormone treatments, the non-hormonal medications, the vaginal estrogens, the melatonin for sleep, which is a very sort of complementary compounded form of medication that helps with the circadian rhythm. We also are definitely looking at other complementary treatments that would be helpful. So we know that it's a time to be looking at your calcium intake and whether or not you need a calcium supplement. But I have to say that with a level of caution, because not everyone needs calcium and it actually can be harmful. So that's one that we're looking at, helping women to at least assess whether they could be getting their calcium, elsewhere in their diet. Vitamin D is one that's really good for protecting bone strength and preventing fractures. Because actually one quite sobering statistic is that 1 in 2 women over 50 will have a fracture at some point in her life from there on.
I've heard this, and again, they go a second time not long after, apparently.
Yeah.
So it's certainly from the joints and all of that perspective, I certainly know what that feels like.
Yes.
As someone with osteoarthritis, and I think there's a bit of rheumatoid going on.
Yeah.
So what I was going to say, though, I love just going back a little bit about the fact that there's this discussion that kind of goes offline.
Yes.
Which is great, because what I find is, when you're at a doctor and it's like you're trying to get everything in and you can't absorb it, digest it. So
exactly.
what a great way to do that, so that it gives you a time to take it away and go, okay, in my own time, and I can focus and digest it, right?
Yeah, I mean, it's been really interesting as a doctor practicing on the platform to see how I would take my normal menopause consult and now take it online in a different sort of fashion, where you do extend it over a period of time and give the patient more time to digest. I actually think it can be a better consultation in terms of the outcomes and making sure that you've got all the information that you needed. Because to think that every GP in every single room across Australia would be able to tick all those boxes of all the questions that they would like to make sure they've known before they, hit prescribe and sign a prescription for a patient, is just ludicrous. But with having a standardized questionnaire, we can make sure every single time we know what we need to know about that patient.
And if you haven't got enough, then obviously you've got the opportunity to go back and forth, and because sometimes we get a little bit confused by what you're asking. I mean, it can be, so to get the opportunity to come back and clarify, and what a wonderful way of doing it. It makes far more sense to me. Than just even having a 20-minute consult with a poor GP who's overworked and just trying to be, patching people up. So it sounds like a really efficient way to work, and what a wonderful initiative to start Juniper. So congratulations, Joanna.
Yeah, it's been really exciting.
Talking to us.
Yeah, lovely to chat to you, Lindy.